So here's our data that was initially presented at ISC in LA in 2020. So this is the abstract title, just like the title of the talk. So what we have here is the study rationale. And we knew that VIS was going to make a big difference. We just didn't understand how big it was going to be. So we knew that we were going to be able to detect these automatically. VIS would detect some of these ELVOs and then could start the whole triage process much sooner. So why don't we look at pre-data, pre-VIS data, and post-VIS data and look at the times. So we looked at specifically our CSC, and at the time, our sister hospital, Valley Baptist Brownsville, was the only hospital that we had VIS implemented in at the same time as the CSC. And obviously, as you know, CT scans done, CT angiogram was done, and then it gets pushed to the cloud compared to the old process, which was obviously very cumbersome. So as you can see here on the bottom, the historical workflow from February 2017 to November 2018. So nobody can say this is 5-year-old data. No, this is exactly, the time before VIS was implemented, and I've been here for 7 years working on fine-tuning this program since day one. So even at the spokes, we still had these multiple delays and people having multiple phone calls having to be done with the radiology tech, radiologist, ED physician, house supervisor, then house supervisor calling us to make sure that we could accept this patient. Then we say, yes, let's accept the patient, initiate the transfer. Then you call EMS. It was just a very cumbersome process. With the VIS method, everybody's on the communication tool, patients transferred to ED at the CSC, registered, airway evaluated quickly, sent to cath lab. 66 minutes saved from primary stroke center, CT, CTA picture to comprehensive stroke center door. 171 minutes versus 105 minutes. P-value of 0.016. So significant data here, huge difference. And obviously, we've only seen this, continue to benefit patients. With just having discharge outcome data, we were able to see a 55% decrease in neuro-ICU length of stay and a total reduction length of stay of 6.4 versus 2.9 days. So here, as you can see, 39% reduction in time from primary stroke center to the comprehensive stroke center, 105 minutes post-VIS compared to 171 minutes pre-VIS. 55% reduction in neuro-ICU length of stay, as well as complete hospital length of stay was also decreased. But we all know ICU days cost the most, right? And this is one of the things I like to bring up because it's all about money sometimes with some of our administrators. So it's a great way to bring it up to them. Hey guys, we're getting faster arrival. We're decreasing the length of stay in the neuro-ICU by approximately 3.5 days. It's efficient workflow. They love the word efficient. They love AI, synchronized stroke care. This is how you sell it to your administrators to give it to other primary stroke centers. Then we also care about outcomes, right? That you and I care about outcomes. So patient outcomes are time dependent. Loss of 4 days of disability-free life with each minute delay in thrombectomy. So when you look at the total data, with 66 minutes saved, we have about 265 days of additional disability-free life and 660 days additional functional independence. So this is, from an outcome standpoint, this is huge. So time is money, not just brain. Again, just wanted to bring this up for you who are having some trouble, whether it's this or some other competitor software, but especially with VIS, with the ELVO detection alert and the communication tool, we've really found it superior to the others. We're a beta site and a test site for almost everybody. If you saw my disclosure slide, I work with everybody on equal opportunity, and that way I'm not biased. So PSC picture to CSC arrival, average 66-minute reduction, $1,000 per minute delay. You're talking about $69,000 projected cost savings just per patient, per transfer. Now, he's going to say, well, the patient outcome doesn't come out of my pocket. Okay, well, length of stay does come out of your pocket. So if you look at the average length of stay in a hospital with a mixture of neuro-ICU and stroke unit, the economic value per unit is about $4,900 per day of stay. So if you look at the savings, we're about $12,305. That's total length of stay we're looking at. Now, if you want to break it down into just neuro-ICU length of stay with the 3.5-day drop, it's actually more significant. But for our money guys, the CFOs, they call themselves the money guys, they cared more about total length of stay. And hey, look at this, $12,000, that's one patient. So come on. I mean, you do literally 3 patients, you've covered the cost of this thing.